morning, everyone. Let's start the episode of today. I'm Dr. Pierfrancesco Corvo, Italian doctor joining UAE from 2018, working in Sheikh Khalifa Specialty Hospital in Ras Al Khaimah. There are two estimated colleagues with me today. Please introduce yourself.
So, good morning, everybody. I am Dr. Mohammed Sharif. I am a consultant interventional cardiologist working in Sheikh Tahnoub bin Mohammed Medical City in Al Ain.
Good morning, everybody. I'm Dr. Isa Zahri from Zaid Military Hospital, Abu Dhabi.
Today we will focus on renal denervation. It's, let's say, a recent new joint practice that we are facing every day. We should discuss about the action of this new procedure that now is becoming very common in our Cath lab, especially for interventional cardiology. So, what do you think? Why renal denervation is coming back after so many years?
First of all, we have started with renal denervation almost 1 decade ago. But after the Simplicity 3 trial, we had some sort of a neutral study. Therefore, the enthusiasm we started with was not strengthened with the data of the study. Therefore, we stopped because it didn't have positive data. But after 10 years, and because of a lot of positive studies, like Radiance, hypertension, solo and trio, and also the new study, Radiance 2, we have now a good evidence. We have a modest decrease in hypertension values for patients who have renal denervation. Therefore, we started again with the renal denervation, and with this modest decrease of blood pressure, we can add to the welfare of our patients and to decrease also the cardiovascular risk factors that can be helpful. So renal denervation is becoming again a key player in the control of hypertension, of course, on top of the medications.
What do you think? Which is the perspective of in the region?
So, it's hypertension still it's still a challenge, regardless of what we did in the past. Renal denervation was actually not a new idea. It was introduced several years before. We have a lot of challenges here in our patient. Our patients are usually young patients, difficult to convince for medications. They came usually with a complication, late presentation. The perspective of renal denervation is actually opening a new doors for our patient as well. The new studies in favor of the renal denervation, and it actually give us a new era of management of hypertension as well.
Can we just explain briefly how the procedure is performed? How can we just make it simple? Because as intervention, we like simple things.
It's of course an interventional procedure. It's not a complex procedure, but before we start, you have to be aware.
It's not boring at all.
You have to be aware of the anatomy of the renal arteries. You have to be experienced enough to do the puncture and to engage the renal arteries. The procedure itself, it's not a complex one. It's the procedure times about 40 to 45 minutes, and the patient is sedated, and if I say the complication rate is not more than the complication rate of a normal interventional procedure, and in the best hands, the complication rate is almost zero. This is, my opinion.
So how it works when we are facing and we are just pushing the catheter inside the artery? What is exactly doing the ablation?
So it's actually a very simple procedure. Any interventionist can learn it very quickly. Most people think it's a long procedure. It's a very short procedure. Usually the patient can be discharged at night if you don't do general anesthesia. And most of them actually They are not in need of general anesthesia, just a sedation, and they can actually discharge at night. The focus of this procedure is in the sympathetic nerve. There is the idea of controlling blood pressure is well established since long time by the sympathetic nerves. So the reduction of the sensitivity of the sympathetic nerve is the major objective of this procedure. Given that it's very safe, does not harming the renal parenchyma itself. It's a very simple procedure as well.
Very good. But actually, when we are starting this program with renal denervation, what do you think? How it does reflect in our normal practice? I mean, when we are facing this uncontrolled hypertensive patient, which is the benefit that we are providing when we are suggesting to go for this invasive procedure?
Yeah, if we see the data, the new data for the renal denervation trials, we can clearly see that we can achieve doing renal denervation a decrease in the arterial blood pressure between 5 and 10 millimeter mercury. And this decrease has a big influence on the patients and on the compliance to drugs and on, of course, long-term cardiovascular events. The best thing is that we have clear selection criteria for these patients according to the trials. And if we see the guidelines, if we see the data, patients who are having 3 medications and with uncontrolled hypertension, or 4 and 5 medications with controlled hypertension, they are good candidates for the renal denervation. And we have also some long-term data now that we achieve a modest reduction of the blood pressure, which is beneficial for our patients.
In your opinion?
I totally agree with Dr. Sharif. Most of the research, most of the trial now shows that there is a reduction on the blood pressure up to 5 to 10 millimercury. So it seemed to be a small reduction, but this small reduction is translated to a reduction in the cardiovascular risk of about 5 to 10 as well. It's similar to giving aspirin as a primary prevention, this is the way I try to convince my patient. It's a huge reduction in the cardiovascular risk. I think still we need more trials to reach the point where we could say it's a convincing procedure. But even with these trials we could actually say there is a margin of improvement in the hypertension.
Yes. Exactly, regarding the patients, I think one of the most challenging parts when we are starting the program is the selection of the patients. So what do you think, how we can, let's say, involve other doctors like nephrologists, radiologists, internal medicine doctor to support us and to help us to recruit patients that actually deserve to have this procedure?
Yeah, I can tell from our experience in Sheikh Tahnoun. Before we started the program, we have a multidisciplinary team from us cardiologists, interventional cardiologists, endocrinologists, and nephrologists. And we sat together and we established the selection criteria for the patients and the pathways of the patient's journey, when to start and how to reach for the renal denervation. For example, every patient is fulfilling this criteria, taking 4 or 5 medications or uncontrolled on 3 medications. We have a specialized clinic now for hypertension, and we start to screen the patients to exclude secondary causes of hypertension. We send to the endocrinologist, to the nephrologist, we make renal Dopplex, and after excluding everything, he comes again to our clinic after doing, of course, an ambulatory blood pressure to confirm the uncontrolled hypertension. And then we start talking with our cardiologist, and then refer to me or one of my colleagues, and the procedure is done. And after that, we follow up the patient also in our clinic, because the effect of this renal denervation, it is not acute. We need to wait for 1
Yes.
to 3 months. Therefore, the follow-up of the patients also is in our specialized blood pressure clinic.
And what are you saying to the patient when you have to recruit him? I mean, how are you convincing him to receive this invasive procedure?
So I think you have to be honest with the patient, give them the full picture, tell them that it's not treating the hypertension. Our aim is to reduce the blood pressure and reduce the number of medications. You have to be honest with the patient, clear about the thing, because this is how the post-procedure pathway will go. I agree with Dr. Sharif, good selection of the patient is crucial, especially if you are just starting the new program. It's very important to give more effort in selection of the patient. Make sure that the things are being well organized, exclude secondary hypertension, make sure that the GFR is more than 40. There is a lot of off-label use of renal denervation in patients with renal dialysis and with reduction GFR. I think if you're just starting a new program, just try to avoid risky procedures. And then the more you give preparation for the procedure, the more you'll have a good result.
Yeah, you are just, both of you are just underlying the importance when we are starting this, let's say, program, to establish a real program, a plan. So what did you do in your center to establish this program, to start renal denervation, even for the device choose? What are you doing?
So, as I said before, it is not a one-man show. We have to build this multidisciplinary team, cooperation with the nephrologist and the endocrinologist. And when we start this service, there are clear guidelines. Which patient will be referred to the blood pressure clinic, which investigations will be done, checklist for every patient, and if the patient is suitable, he will get the procedure. And the most important thing, that we have a good feedback policy, because the referral of the patients is very important, to talk also with all the other colleagues from the other hospitals, and to make the referral of the patient very simple, to get a very clear decision for their patients.
Do you think that having in every hospital a centralized hypertension clinic can help to centralize the referral coming from the other hospital?
I think it's crucial to have a centralized hypertension clinic. It's just not to just recruit the patient, as well to follow up the patient. It's not just only doing the procedure and then just nobody is following this patient. I just want to emphasize as well, it's very important to give lectures and to give the information as well for your colleague, the endocrine people and the internal medicine people, because they are the people who see more of these hypertension patients. So hypertension clinic is crucial. Post procedure follow-up and monitoring is crucial as well. And I think the more you give time for the follow-up, the more you will have the good result you will have in the future.
Let's be a little bit more practical. Can you share with us a brief case that in your experience was very linear and that is showing a good outcome for a patient, one of yours?
Yes, I can give an example from one of our patients. Is the young patient, 48 years old. He had about 6 or 7 medications for hypertension, full doses from this. And he came to us, it was before we established our blood pressure clinic. And of course, we did the ambulatory blood pressure monitoring. And because he's a relatively young patient with these medications, 6, 7 medications, we sent him to the endocrinology to exclude the secondary causes and into nephrology. And we did renal duplex. We excluded everything, also coarctation, everything. And then we have talked with him about the possibility to do renal denervation. Of course, as Dr. Isa said, we don't say we will cure your hypertension, because hypertension, if it's primary, it's not curable. But we told him we have an option. We can reduce your medication, because 6, 7 medications was irritating him. And we told them, okay, we have this procedure and we have good data, and the chance that we can reduce some of your medications and control blood pressure is there. And he agreed. The good thing is the procedure was done, like I said, 45 minutes. He was discharged on the next day. And then we saw him 2 weeks after ambulatory blood pressure monitoring we have done. We didn't see a lot of effect, but after 1 month, we have seen that the blood pressure is going down, and we reduced his medications first by 2 medications, and after 3 months, we reduced 1 medication. Now he is on 3 medications and controlled hypertension, and the blood pressure is now controlled only under 3 medications. He is happy, we are happy, and this, I think, one of the good examples for renal denervation.
Do you think that anatomical feature during the procedure can change your approach?
It's not gonna. I don't think it's gonna change your approach. It will give you more challenge. You have to be careful. I remember the first 2 cases I did, where I have a very tortuous renal artery branches. In Medtronic, you aim to do the distal part as much as you can. So your catheter have to reach in the distal a little bit on the distal branches. So sometimes you will have some challenges to deliver your catheter, but as an interventionist, you can actually overcome these challenges, because it's not a new thing for us. We are actually working with the coronaries, so we have more anatomical challenges than the renal artery. So you could actually have a support wire changing to another wire. Some people even use the guide liner to give them their support. The procedure itself is not very complex. Most of the complication is access related. But as I told you, it's just going to take you more time to just override these anatomical challenges.
As we know, this procedure is still in class 2, no? Class 2B. So what do you think is the future of this procedure? Do you think we will have more patients to treat? We will have good data to show? We will have more devices to be used? Do you think that radio frequency can be different from ultrasound? Which is the future?
The data that we have now are very promising, and I think that we have something to start with. If we wait for longer term data, I think we will have also better control of the blood pressure. If you want to compare the devices, we don't have till now a randomized trial to compare 1-to-1 between ultrasound and radio frequency.
It's an idea.
But we have to wait for that. I cannot argument which system is better, but we are happy that we have the renal denervation as a tool to help our patients. And in the future, we hope that we get more advanced technology, that we get more understanding of the pathology of hypertension. And we will see. 10 years ago, this technology was dead. Now we have revived it again. As I told you, the data are very promising. So the RDN is there and will stay also.
I think here in this population, we have around 40% of hypertensive patients plus diabetes. The reduction of blood pressure is showing reduction of cardiovascular events. So I think especially here, we should work on population. What do you think?
I totally agree with you. Our population is a little bit challenging compared to other populations. RDN is a promising technique that actually open a light for a new approach of management of hypertension, especially in our population where the patient actually non-compliant to medication. They are difficult to convincing for reduction in the hypertension. I think the future of RDN is promising. We just need some time for more trials and more procedures to make sure that the reduction is valuable.
So we can just conclude in saying that renal denervation has moved from theory to practice. It's a safe procedure. It's showing interesting data. It's improving the outcomes of this patient. So in the right hands, I think we'll have a good impact on the population. So thank you both for joining. Thank you for listening, and see you.
Thank you.
Thank you very much.
Thank you very much.
Thank you.